Today, we are doing a critical deep dive. This is specifically for you, the resident getting ready for board exams like the FRCS. Our topic is vascular anomalies. We're not focusing on the minute details of clinical management, but on the core, non-negotiable facts you need for the written and oral exam.
Exactly. Our mission here is to distill the highest yield information and give you a clear, memorable framework.
We're jumping right in. Classification systems, clinical presentations, the things that set you on the right path for diagnosis from the get-go. And just a quick note, if you want to see these concepts applied to real-world scenarios, complex surgical planning, MDT decisions, the latest papers are specialized clinical cases, and Journal Club episodes are available with a premium subscription.
And that structure is so vital here. I mean, vascular anomalies are complex. They're often managed by a multidisciplinary team in super-regional centers. So your job in an exam setting is to prove you speak the language. Classification isn't just academic, it dictates everything. Prognosis, treatment, the works.
Okay, let's unpack that foundational structure. What is the one classification system we absolutely have to know, and how does it draw that line in the sand between the two major groups?
The standard, the only one you need to quote, is the 2014 International Society for the Study of Vascular Anomalies classification, the ISSVA.
Which built on the Mulliken and Glowacki system?
It's the evolution of it, yes. Yeah. And it is essential. It's the key to diagnosis, planning, management, and, crucially, predicting how a lesion will behave in the future. The fundamental split is between vascular tumors and vascular malformations.
Okay.
Tumors, and the classic example is the infantile hemangioma, are all about endothelial cell proliferation. The cells are actually multiplying. They're hyperplastic.
Yes, it's an active cellular process.
Precisely. Whereas malformations are structural defects, an intrinsic abnormality of development. They aren't tumors. They are present at birth, and they just grow in proportion to the child.
That's the cornerstone, then. Proliferation versus a static structural defect.
That is the cornerstone.
So when we see any kind of mass, the first thing we have to do is rule out the worst-case scenario, malignancy. What are the high-yield, malignant vascular tumors we need to have on our differential?
Two you must know, angiosarcoma and epithelioid hemangioendothelioma. These are in a completely different category and demand an urgent, specialized approach.
Got it. Now, back to the malformations, the structural problems. What's the quick breakdown for the simple malformations based on flow characteristics?
Simple malformations, you're thinking capillary, lymphatic, and venous. Those are all generally low flow.
Okay, the low flow group.
The ISSVA classification also puts two high flow lesions in this simple category, arteriovenous malformations, or AVMs, and the arteriovenous fistula. Flow characteristics are absolutely key here.
Let's focus on the one entity we're most likely to see and manage. Infantile hemangioma, IH. Start with the facts. Give us the numbers we need to memorize.
Right. IH is the most common tumor of infancy, full stop.
Yeah.
The incidence is around 10% in white infants. But for the exam, remember the risk factors. The incidence jumps to 23% in premature babies, especially those under 1 kilogram. That's a huge increase.
A massive jump. What about gender and location?
The male-to-female ratio is about 1 to 3, and location is critical. 60% are in the head and neck. High-stakes real estate.
When do they typically appear? I know they're not always there at birth.
That's right. Only about a third are noticed right at birth, and often it's just a subtle herald patch. The majority pop up in the first 2 weeks of life.
And a deep one might be missed for longer.
Exactly. A deep hemangioma might not become apparent until the child is 2 to 4 months old.
Okay, let's nail the natural history. The 3 phases. We need the time frames and the cellular drivers for each.
Okay. Phase 1 is the proliferating phase. This runs for about 6 to 8 months. Clinically, it's raised, it's bright red or blue, and molecularly, it's driven by rapidly dividing endothelial cells. You have high levels of vascular endothelial growth factor, VEGF, and bathic fibroblast growth factor. It's a vascular explosion.
A growth factor-fueled explosion. Then what happens?
Then you enter the involuting phase. This is much longer, 5 to 10 years. The color dulls, the lesion gets softer, endothelial activity slows right down.
And what's the molecular switch there?
The key player is an increase in the tissue inhibitor of metalloproteinase, TIMP1. It actively suppresses that angiogenesis. And this is when you get deposition of fibrofatty tissue replacing the vascular mass.
And finally, the involuted phase.
Right. The rule of thumb for boards is 100% resolution by age 10 or 12. You might have some residual loose fibrofatty tissue, but the skin looks near normal in about 50% of cases.
That progression, especially the 6 to 8 month proliferative window, is so important because it tells us when we might need to act. So what are the critical life-changing complications that demand urgent intervention?
These are the ones you cannot miss. Number 1, visual axis obstruction.
Right.
If a hemangioma is blocking the eyelid or pressing on the globe, you risk deprivational amblyopia. And the key point is, this type of amblyopia is not correctable later with glasses. You've missed the developmental window.
And you also mentioned pressure on the globe itself.
Yes, that can cause anisometropia, unequal refractive power, which also leads to amblyopia. It's an emergency.
Okay, number 2.
Airway obstruction. It's rare, but it's terrifying. Classically seen in cervicofacial hemangiomas, the so-called beard distribution. The subglottic lesions present with this insidious biphasic stridor around 6 to 8 weeks of age. That needs immediate specialist input.
And the third one?
Ulceration. It happens in about 10% of cases. It's incredibly painful and requires dedicated local wound care on top of any systemic treatment.
Given those complications, let's talk treatment. For exam purposes, what is the undisputed first-line drug for IH, and what are the critical pre-treatment checks?
Propranolol, a non-selective beta blocker. It was a chance discovery back in 2008, and it has completely superseded systemic corticosteroids.
How long is the treatment course, typically?
We usually continue it for 12 months to avoid rebound growth when you stop it. And the pre-treatment workup is very high yield. You need a full history, exam, an ECG, and an echocardiogram before you start.
And the monitoring during initiation.
Essential. You're tracking heart rate, blood pressure, and blood glucose very closely.
Let's break that down. Why those 3 specifically?
Well, it's a beta blocker, so hypotension and bradycardia are the obvious risks. But it also inhibits glycogenolysis.
Meaning it blocks the body's response to low sugar.
Exactly. Which makes the infant highly susceptible to hypoglycemia. Parents must be educated on feeding schedules and the signs of low blood sugar.
And contraindications.
Absolute contraindications would be sick sinus syndrome or a 2nd or 3rd degree heart block, which you'd pick up on the ECG. But the key relative contraindication to know is Facey syndrome.
Because of the arterial anomalies?
Precisely. Giving propranolol in that context risks compromising cerebral perfusion. You could make things much worse.
What about surgery? When do we cut?
Acute surgery, like debulking, is only for functional emergencies after medical treatment has failed. The vast majority of surgery is done years later, in the involuted phase, purely for cosmesis.
And lasers.
Vascular lasers aren't great for deep ablation, but they have a role in treating acute ulceration, or the residual telangiectasia after involution.
Let's shift to the congenital tumors. How do we differentiate the 2 types of congenital hemangioma from IH?
So congenital hemangiomas, or CHs, are fully formed at birth. That's the first clue. But histologically, the key is they are GLUT1 negative. Infantile hemangiomas are GLUT1 positive. That's a classic exam question.
And the 2 types of CH?
You have IOCH, which is a rapidly involuting congenital hemangioma. It regresses quickly, usually by about 14 months. And then you have NICH.
Non-involuting.
Exactly. Non-involuting congenital hemangioma. It doesn't involute, it just grows in proportion with the child.
Is there a critical systemic issue with large CH lesions?
Yes, both large RICH and NICH lesions can cause high-output cardiac failure from all the shunting. Sometimes it even presents on antenatal ultrasound as hydrops fetalis.
Quick question on a common smaller lesion, pyogenic granuloma. Presentation and the 1 non-negotiable management step.
It's an acquired lesion, grows fast, bleeds a lot, common on the face and hands. You can treat it with a simple curettage or excision. But, and this is the non-negotiable part, you must send it for histology.
Why?
To exclude a cutaneous malignancy, particularly a melanotic melanoma. You cannot skip the pathology report on these.
That coagulopathy risk is a perfect segue into the Kasabach-Merritt phenomenon. KMP. What is it and what lesions is it associated with?
KMP is a rare but life-threatening emergency. We're talking up to 30% mortality. It's associated with 2 specific tumors, Kaposiform hemangioendothelioma and tufted angioma.
Not with infantile hemangioma.
Correct, not with IH. The phenomenon itself is platelet trapping within the tumor. This leads to a profound thrombocytopenia, a huge drop in platelets, and a secondary consumptive coagulopathy, specifically hypofibrinogenemia.
Okay, that is a critical setup for vascular malformations. Let's start with imaging. What's the investigation of choice?
The gold standard is a gadolinium-enhanced MRI. It's perfect for assessing flow high versus low and for mapping out the anatomical extent of the lesion.
CT and angiography have a role too.
We tend to reserve CT for lesions involving bone, and conventional angiography is now used primarily for treatment, not for the initial diagnosis.
Let's focus on venous malformations. VMs, clinical clues on exam, and how do we differentiate the coagulopathy here from KMP?
Clinically, VMs are these soft, blue, compressible masses. They swell when the limb is dependent, and you might feel or see phlebolyths, which are little
In the
calcifications.
DIC risk?
Right, very large VMs can cause a localized DIC. And here's the absolute key distinction for your exams.
Okay.
In VM-related DIC, the platelets, PT and APTT, might actually be normal. The coagulopathy is driven by low fibrinogen and increased fibrin degradation products.
So if you see profound thrombocytopenia, you're thinking KMP.
You're thinking CAMP. If you see low fibrinogen with potentially normal platelets, you're thinking VM. That nuance is often the difference between a pass and a fail.
And the main sclerosants we use?
For smaller cutaneous VMs, we often use 1% sodium tetrathiosul sulfate. For the big, deep ones, absolute ethanol is the sclerosant of choice. But you have to be careful. Ethanol carries a real risk of nerve damage. So in high-risk areas, like near the facial nerve, 3% STS might be a safer choice.
Shifting to the high-flow extreme, arteriovenous malformations, AVMs. What's the staging system, and what's the one critical rule of management?
For AVMs, you need to know the Schobinger clinical staging system. Stage 9 is quiescence, maybe just some warmth. Stage 4 is full-on decompensation with heart failure. We usually intervene at stage 3 or 4.
And the critical rule?
The rule is you never ever ligate or embolize the proximal feeding arteries.
Why not? It seems intuitive.
Because if you cut off the main highway, you lose all your endovascular access to the nidus, the central tangle of vessels. And worse, the lesion just recruits a whole network of new collateral vessels, making the problem bigger and potentially incurable.
So the goal has to be obliterating the nidus itself.
Always. Treatment requires super-selective angiography and embolization right into the nidus, usually done 24 to 72 hours before a planned surgical resection.
Okay, we're wrapping up with the key associated syndromes. Let's get a clear differential. Klippel-Trenaunay syndrome, KTS, versus Parkes-Weber syndrome, PWS.
It's all about flow. KTS is a combined capillary lymphatic-venous malformation. It is a low-flow lesion, and it's associated with limb hypertrophy.
Low flow, got it. So PWS must be
High flow. Parkes-Weber adds an arterial component. It's a capillary lymphatic arterial venous malformation. Angiography shows countless microscopic AV fistulae throughout the limb. So KTS is low flow, PWS is high flow.
perfect. And finally, what's the capillary malformation feature that should immediately make us think of Sturge-Weber syndrome?
A capillary malformation, a port wine stain that is strictly confined to the V1 dermatome, the ophthalmic division of the trigeminal nerve.
And if you see that,
You must investigate for associated ipsilateral leptomeningeal and ocular vascular anomalies. It's a multidisciplinary diagnosis from the start.
that concludes our intensive deep dive. If you're preparing for your boards, this framework is absolutely essential. Mastering these distinctions, flow, proliferation, coagulation profiles, that is the path to success.
Exactly. And remembering the why behind it all. Why you monitor glucose with propranolol, why KMP is about platelets, while a VM is about fibrinogen. That's what separates basic recall from true understanding.
And if you found this structured revision valuable, remember our premium subscribers get access to the specialized clinical cases and journal club episodes. That's where we drill down into surgical decision-making and the latest evidence on these complex lesions.
Now here is a final provocative thought for you. Considering the risk of rebound growth after stopping treatment for infantile hemangiomas, how might the natural history of that very long involutionary phase, which can last up to age 12, influence your decision to start or perhaps delay propranolol in an asymptomatic, non-obstructive head and neck lesion that you've noticed early in infancy? Think about that risk-benefit profile over the next decade of that child's life.
We'll catch you on the next deep dive.